You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. In this episode, I talk with Dr. Mukul Mehra, a practicing gastroenterologist and founder of IllumiCare, now part of Premier's Stance in Health. We discuss the hidden costs of care and the unintended consequences of well-meaning clinical decisions. We explore how low-value care can trigger therapeutic cascades that harm patients and frustrate clinicians. Dr. Mehra shares how a single patient bill led him to build a platform that surfaces real-time cost data at the point of care. We discuss contextual nudging, clinical financial decision support, and how smart design can help clinicians make better choices without feeling micromanaged. If you're a health system leader trying to align incentives, reduce waste, and empower your physicians, this conversation offers practical insights on how to make it easier to do the right thing. Let's plug in. Dr. Mehra, welcome to the podcast. How are you today, sir?
I'm great. Thanks for having me.
And where do we find you today?
Birmingham, Alabama, side of the IllumiCare office.
Awesome. I look forward to kind of hearing more about IllumiCare and how you got there. But let's start at the beginning. You've always, since you were a small child, have always wanted to run a company. Is that true?
Absolutely. After the APGAR score of 9, I declared that I'm going to have a company in healthcare one day. And they downgraded me from a 9 to a 7 on the APGAR.
So are we talking about the 1-minute APGAR or the 5-minute APGAR? It's very important. Our listeners want to know.
You know too much. It was the 5-minute APGAR.
It was a 5-minute APGAR. You got a 9. Well, that's good. That's good. That's how you get into some of the best schools. So let's assume that we're both being sarcastic, and that's not what you've always wanted to do. You wanted to go to medical school, I presume, and become a physician.
I love math and physics. It still has always been my passion. And so it was really the electrical engineering route that I thought I was going to go to. I went to school at Northwestern, but I found the human connectivity within the medical profession as the ultimate, guide towards picking medical school.
And you became a gastroenterologist. How does one choose that specialty? I'm always just curious. Is it the procedures? Is it the disease processes that you deal with? Or is it just you fell into it?
My uncle is a gastroenterologist. So certainly I grew up with a background in gastroenterology, but you're right. I enjoy a profession where your diagnostic skills were valued and you had therapeutic interventions doing a procedure, and you were the proceduralist too. Our design often in gastroenterology is procedures in the morning, clinics in the afternoon, inpatient rounding in between. That was ideal to me. That or cardiology. I chose gastroenterology. Electrophysiology fascinated me the most.
Okay.
It is the ultimate compendium of an amalgamation of physics, electrical pathways, and the heart stopping or going haywire.
So you were and are a practicing gastroenterologist. How did you get into this idea of starting a company and what was that process like? What problems were you seeing?
The biggest problem I saw was a buzzword called value-based care. And it was fascinating to me that we were going into value-based care, and we thought we had a pretty good handle on at least what we consider high quality. We didn't have a grasp of cost, especially at the provider level. We were going to enter value-based care and not fundamentally expose costs to the people who actually are ordering therapeutic. That was a problem. And the biggest inspiration for me came when it was a patient of mine, she had cholangitis, she had renal failure, she had pancreatitis, potential sepsis. So me and 4 other physicians took care of her. It was about an 11-day admission. But what really happened at the end of this 11-day admission is we saved her life. I did an ERCP with a sphincterotomy. It wasn't very hard, put a stent. And when she came back to the office 6 weeks or so later, she looked distraught. She showed me her bill. And that began the journey of deconstructing a patient bill from an inpatient stay into line item costs, not charges, even though charges appear on these bills. So what is the true cost, or as close as we could get to the true cost of the things that we did to this patient? Medication ordering, lab ordering, radiographic study ordering. And it was fascinating to me because I convened this group of 5 physicians back and I said, look, it took me a while, but I want us to do a chart review in retrospect. And 43% of the stuff that we did to that patient, we admitted was probably not needed. This is the problem because a portion of that bill now hits the patient's wallet. And we know that low value care is problematic to health systems, but it's a real problem to the patient. It was fascinating to me. I had this moment where I was like, we've always talked about iatrogenic risks. I mean, it's a Greek word. Iatro means healer, genic means the producer. So the healer produces unintended consequences from their therapeutic decisions upon a patient. Like, we know this happens. There's been a recent article on excess imaging being done, and it's radiating our patients when we do CTs or we draw a lot of blood from a patient. We make them anemic. Those are iatrogenic risks. But the real iatrogenic risk now in 2025 is the financial consequences of what we're doing to our patients when we're ordering meds, tests, radiographic studies, whatever they are, and they're low value.
Let's talk about low value care. I think outside of the clinical world, it's a little confusing. These are not things that have no value that you shouldn't do, right? You hurt your foot, so I get an x-ray of your arm. Like, no, probably that's no value. But low value care are some things that we do that as you mentioned, kind of in hindsight, maybe we didn't need. What are some examples of that, of low value care that you see in your world, of things that you might have done or might still do sometimes?
Well, like that patient who had pancreatitis and a stone in the bile duct. Well, she had pancreatitis, so we feel that we're going to order a lipase and an amylase. They come back high. We've established the diagnosis of pancreatitis. There is no forecasting of recovery based on sequential levels of amylase and lipase. So it's low value. Does it feel good when their amylase and lipase come down? Sure, that's human nature. Yet, it doesn't in any way portend how that patient's going to do, because the definition of severe pancreatitis is not based upon the lipase or amylase elevation. So it's dually wasteful. One, you're ordering them sequentially. Two, you're ordering both of them sequentially. Each of these lab tests have a cost. By the way, they are an extraction of blood too, and it's not super comfortable getting blood drawn. That's low value care. But we don't do it with any sinister motives as physicians.
I love that example. One that I've heard is ordering EKGs routinely before non-cardiac procedures. So you're having a knee replacement, and we'll check your EKG just to be sure. Again, for patients who have no heart disease that is known, it seems like that wouldn't do any harm, and except for the money, of course, it costs money, but it does cause harm, right? Because it's not been shown in studies to be helpful. The benefit doesn't outweigh the disadvantages. The disadvantages, besides cost, are, it takes more time. Inevitably, we find something. And the conversation almost always goes like, yeah, I ordered this EKG. It's slightly abnormal. I'm not sure it means anything, but now I need the cardiologist to take a look. And then the cardiologist says, well, it's probably nothing, but if you're going to have surgery, we should probably make sure it's not. And then let's order some more tests, which delay the knee procedure that you were trying to get in the first place. And some of those tests involve being poked with needles and having dye injected. And people have allergic reactions and other kinds of problems sometimes. And so these things that seem like, again, we're calling them low value, but sometimes they're actually harmful besides the money and the time. So getting rid of them or minimizing those low value tests, again, you're perfect with, you don't need lipase and amylase. You probably only need one. And you certainly don't need to check them every day to see that they're going down when you can tell the patient's doing well otherwise. We have science. This is not just our idea, right? There are studies that show that, hey, whether it's going down quickly or going down slowly, doesn't really matter once you've established that you have a diagnosis and you're dealing with it the right way.
Yeah, absolutely. That's well said. In fact, you're describing a longer term harm, which is the therapeutic cascade. Like if you take that same patient, okay, so now they went to see the cardiologist. The cardiologist orders a lipid panel as part of their workup. Well, the LDL is a little bit high. So now the LDL is high, so they get put on a statin. Maybe the data on using statin for primary prevention with that LDL is not high. I'm a hepatologist too. So now 3 months later, that patient's ALT is 68. Now they're coming to see me for elevated liver enzyme. And so the consequences of low value care and the therapeutic cascade of future unnecessary tests, it's very hard to quantitate the financial value or loss in that case, but nevertheless it's felt by the patient in our healthcare system.
I have not heard that term therapeutic cascade, but I love it. It reminds me, one of the things I used to tell parents as a pediatrician, I would tell them that my job was to do as little as possible for as long as possible. And I would have used the term to prevent therapeutic cascade, right? Because should we get a lab? Well, if I get a CBC, something's coming back abnormal on that CBC, and guarantee it, right? And it might be a series of letters that I'm not even sure exactly what the MCHC does, but there's an MCHC and it's off by 0.1. And now do I need to send you to the hematologist to make sure that's nothing? And yeah, clearly you've helped us clarify that low value care is something to be avoided. And again, there's always circumstances where you do want to get a lipase and an amylase, and you might want to repeat those because the diagnosis is not clear. And so that no one's talking about that, but we are talking about routinely doing things that really don't have any science to support them. And so you saw that problem. How did you go about trying to solve it?
First of all, the first challenge was surely somebody's exposing costs to providers in the acute care setting. We can talk later about why we chose the acute care setting as our area to focus on at IllumiCare, but they weren't. The cost accounting system data does not talk to the clinical ordering system in the electronic medical record. So, for example, magnesium, you're acquiring 50 bottles of 20% stock solution of magnesium. Each of the bottles is 50 milliliters. Well, that's not how we order magnesium as a physician. We order 2-gram Magron IV. That translation doesn't exist because we want to get to the actual acquisition cost of the magnesium, not what shows up on this bill, this charge master bill. And that translation is very, very difficult to do for medications, especially intravenous medications and drips. It's not as hard to do for tablets, but the costs change. And for laboratory and for radiographic studies, there's some proxy measures of cost for those. So we began to expose costs at the point of care. If you expose them retrospectively or in an aggregated fashion, it tends to have very little meaning to physicians who are very metrically driven. And so we had this challenge of, well, how do we put the cost right where the physician is in the electronic medical record? They're reviewing a patient. That was going to be a challenge.
So yeah, the translation between the bulk and how that actually gets delivered to the patient, that's a problem that CFOs and folks in inventory management have been having forever, right? How much does it cost to take care of this patient for a heart attack? I don't know, right? How much does the room cost? How much does the nurse cost? How every lab value we seem to know, but often we're paid nowadays through a DRG, through a standard number. A patient has a heart attack, that's worth X thousands of dollars, and we don't really care how much it costs you. The insurer or the government doesn't really care. Obviously, the hospital, from the chief financial officer on down, does care. And so what are some of the things that kind of the problems that you've had in making that come true in terms of being able to say to docs, hey, this is actually going to cost this much money? Like, how do you actually do it?
So make a physician log in, put their password, find a patient, look up something. It's not going to work. We all know that. I mean, there's enough clicking around in the electronic medical record that putting a link or a hyperlink to expose cost wasn't going to work. So the first attempt we had at exposing costs was to create an EMR agnostic ribbon that would surface the insight at the point of care. Like, hey, you're ordering this lipase. Did you know it's cost this much? Or here's a receipt view of the things that you've ordered. And it was fascinating to see how enlightening it was to physicians, to clinicians, that they could now for the first time see the cost of a lab, cost of the medication at the dose they were giving per day, the putative cost of the radiology study. And it was really, really cool for like 2 months.
One thing I just want to call out, that design kind of principle, that learning principle, the way adults like to learn versus the way kids are forced to learn is, yeah, I'm happy to learn something as long as it's at the time that I need to learn it, right? And that was, at least for the first 2 months, that was key. Don't tell me how much it costs for this other patient or for this other dose, and don't tell me before or after I've already done it. You're telling me as I'm about to order this thing, this is going to cost the patient this much. All right. So 2 months, it worked great. And should we end our story there, or is there more? Sounds like there might be more.
And so the feedback would be that it began to have very little influence in low value care ordering beyond perhaps a Hawthorne effect. So maybe the daily CBCs would go down, or the BMP would go down, or the CMP would go down. But ordering hepatitis panel or ordering lipase and amylase again and again, it was very hard to prove that we were having an effect. And honestly, the physician feedback was, well, it was neat to see costs for a month or two. I think I got it. And we don't really pay as much attention to the cost. And somebody came to me and said, it's really hard to think through an algorithm of care without knowing when you may be doing something low value and amalgamating that with the clinical literature that proves it's low value. So what I understood was, look, we're showing you costs. It's too much of a cognitive load exercise for you to think through where costs are valuable. Like, it's really not valuable to see the cost of levothyroxine. If the patient has hypothyroidism, the tablet's generic, 10 cents. What are you going to do with that? It's there. The Tylenol, acetaminophen, it's 2 cents for a 500 milligram tablet. And so we had to begin to reduce the noise and build a data set that we called clinical financial decision support.
Before we go on, let me just call out the Hawthorne effect that you referenced, that some of our listeners might not be aware of. What is the Hawthorne effect, and how do you think it came into play?
I mean, the Hawthorne effect is like when my wife says she really appreciates me folding the laundries, which I hardly ever do. But then when she comes in the house, I find some laundry and just start folding it. But when she's not really looking, do I go around and fold laundry? No, but I should.
I've never heard it explained that way. The way I've typically read about it, I think it was there was some factory, and either it was called Hawthorne or was in a location called Hawthorne, but they started doing some experiments by changing the lighting in the factory, and they made it brighter, and they found that productivity went up like amazing. We changed the brightness, made it brighter, productivity went up. Everyone should clearly now make everything brighter in the factory. And then they lowered they left it that way for a while. Then they lowered the lighting, and you know what? Productivity went up. and the idea was, hey, if I perceive that you're doing some research on me or my work that's around me, I'm going to be more attentive to whatever it is I'm doing. And so whatever it is you're checking for, you might actually find it. And so it makes complete sense to me that all of a sudden there's, hey, this is how much that costs. Well, clearly the lesson I should learn from that is that I should take this into account and be better steward of my patient's finances and not order something. So how do you make things, how do you design to take away from the noise and just to your point, hey, if I don't have enough thyroxine, if I don't have that hormone, I need Synthroid. Like I just need it or I'm not going to survive. And so whether it costs 10 cents a pill or $10 a pill, it's really not relevant because it's an expense that has to happen. But there are things where it is relevant. And so how do you pick those out?
That is the hardest feat. So we have close to 1,100 rules around medication, lab, and radiology ordering that take into account the cost of the therapeutic, the cost of some alternative to that, the clinical context that makes those relevant, and then a thorough review of the clinical literature. The goal is, can you choose an alternative path? There's another med, another route of that med administration, another lab, not doing that lab, another radiographic study, or not doing that study. And quality, the outcome could still be the same or improve. And if you can do that and lower the cost in that process, we call that rule set our clinical financial decision support. So clinical decision support just says, well, look, you come in with AFib, you should check for thyroid abnormalities. That's clinical decision support. Clinical financial decision support is, hey, you came in, you have acidemia. If you don't have renal failure and the pH isn't less than 7.2, you shouldn't be using IV sodium bicarbonate. It feels really good to get the pH up. I mean, who wouldn't want somebody's pH up when their blood pH is low? Yet the outcomes, if the pH is low and the kidney function is normal, is that you will raise the pH, but impart no value in terms of morbidity or mortality to the patient's admission. And then there's a cost. So in that case, you don't need to use sodium bicarb. You can use a less expensive crystalloid or IV fluid or not use one. That's clinical financial decision support. And not every clinical value rule makes it through the funnel of clinical financial decision support. That then has to be imparted contextually to the right provider who's ordering it, or somebody in their specialty is ordering it because they've left the service. And there's some clinical parameter inside of the patient's clinical window that says, look, this is treading on potential low value care. And we never say no value care because we're not at the bedside. And you and I have both been at the bedside. We don't like when people not at the bedside or technology is not at the bedside make absolute declaration.
So I think what you've called this, and you've just kind of given us a clue, is contextual nudging. So of course, most of us know what a nudge is, just a little push in the right direction, which to your point, sometimes it's wrong, right? Sometimes, yeah, this is not a 9 out of 10. This is the 1 out of 10. And I don't want to do that, but make it easier to do the right thing. You push me a little, but the key is the context. And so knowing what you know, you've sounds like you've written these rules to say, hey, based on the context of what's going on, this might not be the best way. I think it's fascinating, that example that you gave of, well, you want to get the pH back to normal. Doing so doesn't seem to actually benefit the patient in the short term, doing that quickly. And so you're simply doing something to make you feel better, but you're not actually doing something to make your patient feel better. And that kind of nudging is completely appropriate. And so that just works in the EHR. I just get that nudge. How does that work? Is it differ based on the kind of electronic health record I'm using, or does it look like it's coming from inside the EHR? Who I feel is nudging me?
Well, it's meant to feel like the institution is nudging you. IllumiCare uses really a black framework to nudge because we think providers have been anchored into ignoring native EMR looking nudges, and they're ephemeral. Physician autonomy is super important. Clinician autonomy is super important. I mean, physicians are super highly educated. Oftentimes, they've been to school longer than anybody at the health system or anybody, on the payer world. And so we enjoy autonomy. And the nudge actually appears when you're in that patient's chart. You're the right provider to address that therapeutic because it's within your discipline. And then the nudge disappears. It fades away in 7 seconds. Now, that isn't really the mechanism that exists when you put insight into the native EMR alert window. But we know that what's important is to use all of those modalities. So with Epic and with clients, we push our clinical financial decision support insight into the Epic OPA architecture. We built it alongside of Epic and alongside of other clients. And when does that more heavy-handed approach occur? It occurs when the data analytics show that you succumb to low-value care within that order more. You're an outlier. So we look at low-value care variation. Look, I think clinical variation is kind of important, but it's always going to be there. We're not all pieces of substrate for building a car, a Toyota or a Honda. We just don't understand enough about different phenotypes of patients. So there's going to be clinical variation. But if you're an outlier in low value care in ordering IV bicarb in patients that don't have a low pH and an elevated creatinine, then you potentially will get that as a hard stop inside of the EMR architecture. Otherwise, it'll just be a passive nudge.
I think most of us don't realize how complicated it is, because it's not a simple rule. If you do this, then that happens. It's also looking at my past history and looking at what the patient is in front of me. Because boy, your point is well taken. Alert fatigue is a real problem. And if I'm constantly getting pop-ups and constantly getting told things, especially if A, I disagree with them, I think they're wrong, or B, I agree with them, but like I was just about to do it, and you're badgering me. I'm just going to start making those things go away, and they're going to be less important and not there. Explain to me about the 7 seconds. That I'm fascinated by this. How did you come up with that idea? I assume it's just, hey, I see it on the screen. If I want to react to it, I will. Much of the time, I don't want to react to it, but it's now planted in my head. 7 seconds, the right amount of time? Is 10 seconds better? Have you done that kind of side-by-side research, or you just kind of picked a number and gone with it?
We picked a number, and I get to use IllumiCare too. So 7 seconds seemed just enough time to digest the content and not feel that it's in any way intrusive. But it's configurable. We had a health system come to us and say, we think 10 seconds allows people to not be annoyed, but they actually will read the abstract because we make a concise statement about whatever, the pH, sodium bicarb is only beneficial if you're acidemic and you have evidence of renal compromise. Otherwise, it potentially provides low value and can be harmful. Here's the cost per day of that. Here's a link to the abstract. And so we can track all of this. Like we could track if somebody makes a change in the electronic medical record where they discontinue sodium bicarbonate, or they discontinue sodium bicarbonate but offer lactated ringers. And then we look at these windows of time within the nudge for that efficacy, because that is how we measure efficacy. Is are you responding to these? And there's two kinds of responses. There's an immediate response and a long-term response that are KPIs for IllumiCare.
Let's talk about physician incentives. Every clinician wants to do right by the patient. It's difficult to sometimes financially or otherwise incentivize docs to do less care, right? And I could totally make the argument, going back to the EKG or anything else that we've talked about from a quality perspective or a low value perspective, that, well, once I had a patient, that's you're in trouble when I start that way. I had this patient one time, because what's coming, which is they didn't fit. This was one where I actually was going to harm the patient by doing knee surgery because we didn't know that they had a heart problem. And even though, yes, you're right, only 1 in 10,000 times does that help, but boy, that was my patient. And so there's the incentive for me to want to never miss anything, and I'm not really seeing the forest for the trees because of that. So are there customers of yours who have figured out some way of incentivizing either through money or other ways of, hey, you're doing the right thing, we want to call you out?
Yeah, absolutely. And it's a core strategy for IllumiCare when we engage a partner health system to begin to think through that. Why? Because thinking through cost as part of your clinical algorithms, that's not going to save you time. I mean, IllumiCare is not a time saver, the stewardship module we're discussing. And whether it's a little bit of time or more than just a little bit of time that a provider is having to think through low value care suggestions, there is some cognitive load to that. And physicians, providers should be rewarded for that. So the health systems like MultiCare was really a pioneering health system for us. They recognized that one of the 5 quality metrics that they have wasn't being achieved by their hospitalists, and it was very frustrating. It's one that was honestly a metric that the providers didn't think they had complete control over. The health system had a tough time tracking. So they scrapped it and they replaced it with low value care reduction. And we did data modeling on what is their low value care ordering before IllumiCare, had gone live, and what is a threshold that they would have to reach. And if you reach it, it allows the bonus. So it is not just incentivizing reduction of care, it's really curbing low value care. And that is a real quality metric because of all of the reasons that we had discussed, of the consequences of low value care to the patient. And providers were like, well, I totally can track this. And by the way, in real time, I'm seeing these suggestions and I'm not expected to follow all of them. You allow me a window of adjudication, understanding that not all of these are clinically relevant. And then there's techniques, like there's a team effect. I'm a big fan of building incentives that are a team effect, because if one provider is like, whatever, I don't care. Don't care if it hurts the patient. Don't care if it hurts the health system. I'm tired and overworked. Oh, that's fine. I don't care about my bonus. Well, now you're having an effect on the whole team of hospitalists. So they're models that, look, you're part of a team. And really, honestly, the health system and the patient are part of your team, but you're part of a more immediate team, all of your other hospitalists. So if you want to tank reduction of low value care, you're actually hurting the rest of your team that is taking this cause on. And that is a fundamental model that we lead with in the engagement phase of IllumiCare, discussing this with the health system. And they can't always pull it off right when IllumiCare goes live, but it's somewhere on the path, the happy path of, fine, in 6 to 9 months when it's up for negotiation, let's do this. So,
what about putting various ranking physicians? I have found, and this might be a shocker to you, and I believe you're sitting, I have found that physicians are very competitive. Is this a shocker to you? Are you still with us? Or do you? Yeah, no, I think it's a well-known fact. And I've seen physicians who have that kind of attitude that you just described of, I don't think this is important. I don't think this is really valuable for my patient, and I'm not going to participate in this at all. And then someone has the courage or stupidity to put up a list of 100 doctors in the group, ranking them from most consistent with what we want them to do to least consistent, with names and potentially numbers. And boy, I have seen physicians who are like, I still think this is dumb. I still don't see any purpose, but there's no way I'm going to let that guy outscore me on anything, because I don't think that guy's that smart. I'm going to beat him, even though I don't care why. I just want to beat him. Have you used any of those perspectives?
we do. We have an app. So after about 100 days of being live with the nudge technology, every provider can see their low value care spend per admission compared to their service. But we don't expose all the names for any one provider. But the leadership chief quality officer, chief medical officer do get a list of those providers. And like, it was fascinating. There was one provider who would order magnesiums a day after one had been normal 1,084 times in the last 6 months. She was a clear outlier. But other hospitalists were doing the same thing too, just not that many times, even when we ranked it by case mix index. We exclude patients in these detailed analyses, like they couldn't have been on a magnesium drip, they couldn't have been on, an obstetric service. So why is it still happening? And at that point, it's not IllumiCare who's going to be any more effective. It's really going to be somebody at the leadership level saying, did you know, like, you are by far an outlier in repetitive magnesium order in patients not on TPN, not on magnesium drip. Like, why do you do this? Oh, and by the way, we had the stats that 97% of the time that they reordered it, it was still normal. So that's how you empower, change. And no doubt, I mean, one of the sentinel experiments I did before IllumiCare as an ERCP physician, I knew we didn't have to, and these were outpatients, use a stent pusher to push a stent up. When you do a sphincterotomy, you cut the sphincter so that you can extract a stone. You just save your sphincter toe. Just don't throw it away. And then when it's time to push a stent up, you just use the sphincter tome, put the stent on top of it, and push the stent up. Well, the stent pusher from the manufacturer, I looked up because I was curious. Well, what does a stent pusher cost? It was $104. And so I began to create a list of $104, who's using stent pushers, who uses them the most. And so I of course, used none. And within 6 months, we stopped ordering stent pushers in the GI lab. None of this savings goes back to the physician. But people would come up to me and say, well, how do you put a stent if you're not using a stent pusher? And I would show them, come, I'm doing an ERCP, I'll show you. Because nobody wanted to be the physician that was now responsible for ordering stent pushers. And when we go back to the GI lab, we reduced stent pusher ordering and the expense on stent pushers so much that we felt comfortable asking the finance team for a cholangioscope. Well, look, if we're saving $60,000 a year on stent pushers, we didn't need them, and the cholangioscopic system is $40,000. We felt empowered to asking for that, and these are the alignment and synergies that are needed in healthcare for propagating stewardship or low value care reduction, so that all the entities involved, it's a win-win: the health system, the patient, and then the providers. So these are the ways that we model incentives, even for subspecialists too. Like, if you do these things, look, the next time you need something, the finance committee will know, or the finance committee will say, well, look, you want this, you want another APP, we need to see some more efficiencies here. Perhaps we can get you an inpatient hospitalist APP down the road. And this is called alignment, which, we've always been a misaligned healthcare system.
Alignment is essential to get everyone kind of rowing in the same direction. It sounds easy often, but boy, when you understand how the healthcare system works in the United States, and I say healthcare system with air quotes, to get everyone kind of working as a team and making sure that people are paid and recognized for their good work and good deeds is complicated. We could talk about this for another hour or two, but we have unfortunately run out of time. We like to always end with the same question. Are there things that you deal with every day that are so well designed, or is there one thing that's so well designed it brings you joy when you deal with it?
Something I use every day that is super well designed is, honestly, it's the swimming pool.
The swimming pool.
Yes, it is not technology. I don't know if the answer is supposed to be technology.
No, but go on. I'm stopping you. I want to hear.
So this beautiful construct, which in America tends to be 25 yards long, in some parts of America and in Europe, it's 25 meters. It could be 50 meters if you're lucky. It has this black line, and it is so consistent. It has 4 walls. And to me, I took up swimming as a way to break the cycle of overthinking when you just needed moments of mental relaxation. And it was very hard. I mean, as a physician, you have your cell phone, at IllumiCare. People can get a hold of you all the time. And underwater, nobody could get a hold of me. And during that hour, I just find the ultimate therapeutic exercise to me is to go, jump off the blocks, swim the 25 yards, do a flip turn, which I didn't know how to do 8 years ago, but I learned. And it's a very consistent experience. The wall's the same. The water buoyancy is the same. And you can make it as challenging as you want. You can swim butterfly and you'll get short of breath pretty fast. You can swim breaststroke and breathe out of water all day long. But it's therapeutic. It's consistent. And it was a challenge I took up, and I never grew up swimming.
I love it. And what the black line, you mentioned a black line, that's at the bottom of the pool?
It is. It's the center of the lane. Your goal is to swim center. You come off the wall and you're not center. So if you swim 25 yards and swim 25 back and you got off that black line, you may have swam 50.1 yards. So if you're shooting for time and efficiency and consistency, the black line's consistent. You weren't consistent because you didn't stay down the middle.
Yeah. Obviously, I'm not a swimmer because I'm asking what the black line is. But no, that's great. I love that. This has been great. What a great conversation. Thank you for teaching me and kind of explaining some things about how you've done your work. And I wish you only more success. And we'll have to check back in with you in a couple of years to see what new things you've learned and how you've changed people to make it easy to do the right thing.
Well, I learned from you, Craig, too, and thanks for having me on.
Thanks for tuning in. We hope you enjoyed today's episode. For more on Dr. Mehra, follow him on LinkedIn or at IllumiCare.com. Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.